I love this picture. Let's talk about syncope a little bit. Specifically, I want to talk about 7 significant syncope searches on an EKG. This lecture comes from a subset of paramedic school where I teach. I'll leave the link for that program down in the description. I'm Angry Bill. This is Prehospital Wisdom. We know that medicine is medicine and EKG is EKG, whether you're a nurse, doctor, paramedic, firefighter, EMT, whatever you are. But pre-hospital folks have some skills and knowledge that make their job a little bit specific. Let's raise the bar here a little bit. When we're talking about syncope, there's a long and illustrious list of causes that can result in a temporary loss of consciousness. One way to think about syncope is a temporary shock state, as a matter of fact. The definition of shock is inadequate perfusion to organs. For whatever reason, whether it's a pump problem in cardiogenic shock or a volume problem in hypovolemic shock, this is the same thing, it's just shorter. What it comes down to is perfusion is inadequate to deliver oxygen to your brain. Because of that, collapse ensues. So whether this is pre-syncope or syncope, this can be caused by something really simple, like seeing a spider, causing a little bit of increased vagal tone, a little bit of vasodilation, a little bit of wooziness, all the way up to something like a occult GI bleed, lowering blood pressure and resulting in anemia. So that way there's not adequate hemoglobin to deliver blood to the brain. That's not what we're here to talk about. What we're here to talk about isn't specifically syncope, but what you're looking for on an EKG in adult syncope. So like I said, there's 7 significant syncope searches. I'm going to specifically run a complete 12 lead and look for arrhythmia, myocardial infarction or ischemia, Wolff-Parkinson-White syndrome, Brugada syndrome, hypertrophic obstructive cardiomyopathy, long QT syndrome, and arrhythmogenic right ventricular cardiomyopathy. As we go through this, I want you to consider that the rules or the name is less important than understanding that there's something unusual going on. I want you to consider when there's an EKG on the screen, is this something that I would recognize as unusual? It doesn't matter if you can name it. It doesn't matter if you could put your name to it. What matters is when you put someone who has experienced syncope or near syncope on a 12 lead and find something unusual, you have that ability to talk them into going to the hospital and getting it more fully evaluated. So let's talk about all 7 of these one at a time in brief and see what we can learn. This is a EKG from a 72-year-old female. She is conscious, but has no palpable pulses. She is about as white as can be, and if she's not extremely supine, she is no longer conscious. So I suppose it sort of counts as syncope, but when you put someone on a 12 lead occasionally, you want to shout out, well, there's your problem. So when this EKG comes up, well, there's your problem. If someone faints and they have a rhythm like this, it's pretty easy to identify. Arrhythmias in general, I kind of care about when they have a heart rate less than 50 or greater than 120. The specific name doesn't bother me as much. And so I'll get occasionally asked, well, what if someone's in an AIVR? Yeah, that's probably a fairly normal rate and it's probably not their problem, right? So the arrhythmias really matter when it's especially slow or especially fast. Another time when they matter is a kind of a relative to the especially slow is extensive pauses or gaps within QRSs. Those can cause a loss of consciousness as well. And if we find those, we get to hit print, we get to take that to someone that's going to provide them definitive care, and we have proof. In this case, the rate is about 43 on the screen. There's a complete heart block. You can see that the P waves march out. The QRSs march out. One has nothing to do with the other. You notice that the PR intervals are kind of all over the place. The same PR interval never repeats itself. That makes it a 3rd-degree heart block. This also has something else on the EKG, which is a STEMI, which brings us to our next one. Infarction and ischemia. So I'm looking for signs of infarction and ischemia on a 12 lead. That's ST elevation, of course, but also ST depression, hyperacute T waves, T wave inversions, terminal QRS distortion, straightening of the T wave ascent. All of those things kind of end up mattering. All of them sort of jump out. This is the bread and butter of EKG interpretation, especially in the pre-hospital setting. This is something that we should be able to identify fairly easily, so I'm not going to spend a whole lot of time belaboring the point. So Wolff-Parkinson-White, when the accessory pathway is active, creates specific EKG signs. Wolff-Parkinson-White is a syndrome of pre-excitation, wherein the atria depolarize, usually are blocked from entering the ventricle, except via the AV node, which can have a nice little pause and allow for ventricular filling. In some hearts, there's a accessory pathway that electrically connects the atria to the ventricles. It can be constant or intermittent. When it's active, it's showing these EKG findings like are on here. So what I'm looking for is a short PR interval, because there's no longer an AV nodal delay, a wide QRS. The QRS is slightly widened because of the addition of a delta wave. The delta wave is that pre-excitation. It starts depolarizing the ventricle slowly from cell to cell until the normal depolarization takes over. So Wolff-Parkinson-White has a slow depolarization before the main depolarization. Sometimes that can be really, really subtle. I say sometimes, but really often it's really, really, really subtle. You will see all kinds of mimicry associated with Wolff-Parkinson-White syndrome. So the width of the QRS will start pushing the ST and T waves kind of all over the place. You'll get big, tall R waves in V1 and wonder why. So it's simulating a right bundle branch block or an incomplete right bundle branch block, kind of all those things. But our EKG signs when it's active is a short PR interval, wide QRS, delta wave. Wolff-Parkinson-White syndrome, and I think other syndromes of pre-excitation, are associated with tachyarrhythmias. Ventricular depolarization can re-enter the atria and depolarize the atria again and get in a loop where it goes through the ventricles, up the ventricular wall, back into the atria, back over the AV node, down into the ventricles again. It creates a loop for that tachyarrhythmia, and that's called AV reciprocal tachycardia. It's one of the reasons to have SVT. That arrhythmia, even though it's temporary and you didn't catch the actual tachyarrhythmia on your EKG, that arrhythmia can end up being one of the causes of syncope. This is a 24-year-old male complaining of back pain. And I have to admit, most 24-year-old males with back pain don't get an EKG from me, but the EMS crew on this call did a really fantastic job. Now, normally, if a patient on scene is complaining of back pain, that means there's 3 people on scene. There's a paramedic crew plus the patient are complaining of back pain, and any one of them might have the worst one. It's not necessarily the patient. But this crew did a fantastic job by evaluating the back pain and found out that it's not atraumatic back pain. It actually comes from a fall. And evaluating that fall a little bit more, they discovered that it wasn't actually a fall. It was a syncopal event. And because it was a syncopal event, they did the right thing and put the patient on a 12 lead and potentially saved the patient's life. They found this finding. Now, if you just look at this, this kind of relates to what I'm talking about, where you might not know the name of it, and that's okay. Would you identify this rhythm, this 12 lead, as being a little bit unusual? And I would hope so, yes. Look specifically at V1, V2, and V3. That's where our problem lies. I'm going to zoom in a little bit. So Brugada syndrome is a genetic disorder of the sodium channels. It's a sodium channelopathy. It is shown by a right bundle branch block or an incomplete right bundle branch block with T wave inversion in V1, V2, V3. There's ST elevation, which in type 1 or the main type of Brugada syndrome, to me creates a diagonal line from the top of the second R wave, the R prime wave, to the inverted T wave. And it makes that sweet diagonal line that's kind of identifiable. There are other forms of Brugada syndrome that are a little bit more subtle. There's kind of a saddleback ST elevation and a really subtle ST elevation. I think those are a little bit more controversial. The one I'm looking to identify most of all, especially pre-hospital, is this one, with that diagonal line from the top of the QRS straight down to the bottom of the T wave. That's Brugada syndrome. Brugada syndrome, just by the way, has a high propensity for sudden cardiac death. It's confirmed in an electrophysiology lab and is treated with an automatic implanted internal defibrillator, even in young people, like in their 20s, 30s, and 40s. So each time that there's a syncopal event has a potential for sudden cardiac death. And so this is something that needs to be recognized, and even that recognition alone can save a life. So this next one shows an EKG from a 17-year-old male complaining of exertional syncope with weakness. This is a difficult one. This is one that doesn't necessarily stand out as very clear what's going on. In this case, this is kind of a EKG with large QRSs, which is fine because the patient's also 17 and athletic and those kinds of things. It's hard to identify that this is actually a hypertrophic EKG. But if you look over on the lateral leads, there's low lateral Q waves, especially in V5 and V6. Let me zoom into those real quick. So this has narrow, sharp, dagger-like Q waves in the low lateral leads, especially V5, V6, associated with left ventricular hypertrophy, and it's a cause of sudden cardiac death. Usually has a prodromal syndrome or a prodromal symptom of syncope. It's just a genetic thickening that causes a sudden death in a lot of young athletes. It's one that if we can recognize is huge, but this is when we have to specifically seek out those low lateral dagger-like Q waves. This is a good example of the, what is this, sixth finding, I think. So this is a good example of the sixth finding. It's a 56-year-old female about to get a hip replacement. This is a preoperative tracing for her. This comes from ECGpedia because it's such a good example. This is, of course, a long QT. This is genetic long QT syndrome, and the QTC, the corrected QT on this EKG is 0.640, which is significant. I start caring about corrected QT intervals, QTCs, at 500 or greater. So at 640, this is definitely significant. The danger of a long QT is that early beats, like ectopic beats, can fall in the exact wrong spot of the T wave. It's called R on T phenomenon. And I love that word phenomenon. It's one of my favorite words, phenomenon. In any case, that R on T phenomenon can precipitate tachyarrhythmias, pulselessness, etc. Can precipitate syncope, sudden cardiac death, all those things. So finding a genetic propensity for long QT intervals can certainly explain why someone potentially had a syncopal event. And one way or the other is probably something that needs evaluated by a physician or a specialist. So this last group of EKGs, a 44-year-old male had a syncope while on an aircraft in flight. The scheduled flight lands at your local airport, and you go out to take a look at them and get them checked out. This is really common to syncope on an airplane. I think there's something about blood pooling, maybe a dusting of hypoxia from the pressurized cabin, something like that. Whatever it is, people start feeling hot and nauseated, start feeling that terrible feeling coming up. As that happens, as that progresses, they stand up, they go into the aisle to go splash some water in the airport bathroom. Don't actually do that. That's gross. They don't clean those tanks very often. But people stand up in the aisle and faint. Once they're on the ground, you put them back in their seat, and then paramedics will come and check them out when they get on the ground or whatever, hopefully. In this case, though, is there anything on this EKG that stands out that you should be worried about? Go ahead and pause it and look at it. So one thing that stands out, it's kind of abnormal, is there's a whole bunch of T-wave inversion. So specifically in this case, this is a sign of arrhythmogenic right ventricular cardiomyopathy. And so this has inverted T waves, especially on those right-sided leads, because this involves the right ventricle. So this is V1, V2, V3 have kind of the best view of the right ventricle, and that has inverted T waves. Also throughout the EKG, you can see something called epsilon waves. Not to be disrespectful or anything, but essentially what an epsilon wave is an ST segment nipple. ST segment should be smooth. There should not be nipples in ST segments. This can be really confused with an R prime wave or a second deflection of some sort in the QRS. So it's something you have to specifically look for, associated with those inverted T waves and associated with some S wave slurring. This is essentially what's going on with this, is the myocardial cells in the right ventricle are being displaced by arrhythmogenic cells, usually fat cells. Can cause syncope, sudden cardiac death, and cause all those other things that are kind of associated with why we're running an EKG. So those are the 7 significant searches in syncope patients that you want to specifically seek out on an EKG. Arrhythmias, those stand out to us. Myocardial infarction or ischemic signs, those kind of stand out to us. Wolff-Parkinson-White, we need to look for Brugada syndrome with the big diagonal line. Hypertrophic obstructive cardiomyopathy, HOCM, with the narrow, sharp, dagger-like QAs in the lateral leads. Long QT syndrome with a QTC greater than 500, and arrhythmogenic right ventricular cardiomyopathy with the epsilon wave and inverted T waves. Hopefully most of those stand out as something concerning, something not quite normal, something a little bit abnormal on an EKG. Of course, for syncope patients, we're not just focusing on the EKG, we're doing the rest of our whole jobs too. Right, we are evaluating the patient, do a secondary, digging into a physical exam and a history and all the rest of the stuff that we do on patients to try and figure out what's going on. Sometimes people do indeed see a drop of blood and faint, but other times people faint and they're like, I must just be a little bit dehydrated, or I must just be a little bit hot, or I must just be a little bit something. And in the end, it's actually a big deal that would have been found on an EKG. If you do find one of these, you end up looking a little bit heroic that you discovered it. So it's a good habit to do on every syncope patient. Have you ever found one of these in real life? Let me know. Speak up down in the comments. If you like this, make sure and hit like. If you really like it, hit subscribe or share. You've watched it this far. There's someone else that'll get something out of it. My name is Angry Bill. This is Prehospital Wisdom. Until next time, do the 12 lead.